It is my day 66 in quarantine. It is about 2 o'clock in the afternoon here on the East Coast, and we're coming to you live today with one broadcast out of New Jersey, and our guest is Dr. Mark Link, who's coming to us from Dallas, Texas. Good afternoon, Dr. Link.
Good afternoon, Lisa.
It's nice to have you here in our all things COVID conversation corner, I guess we can call it. And today we're going to talk a little bit about what's going on in the state of Texas and in the Dallas region in terms of COVID. And maybe you can give us an update on what's going on in your neck of the woods.
Yeah, so our cases in Dallas are still slightly rising. Our cases in the state are still slightly rising, and our cases in Dallas County are staying relatively stable at 250 a day. Now, some of that's increased testing, to be sure. It's a very good sign that our hospitalizations are dropping a bit in Dallas County. And so that's probably a truer reflection of the number of cases out there. As you know, Texas is opening up faster than probably any other state. And there's a lot of concern here of what's going to happen as we open up, because we still have cases that are increasing.
Okay, I apologize for the noise in the background here. There is a workman in the hallway looking at my air conditioning. Didn't know he was going into the attic while we're going to be broadcasting. Apologies for anything you might hear. Okay. Hey guys, can you keep it down? Maybe he will, maybe he won't. Okay, sorry about that. All things COVID, right? So your numbers are going up. They're opening up. What are you guys encouraging people to do during this COVID time when we got to get back out of the world? At least those of us who are not dealing with underlying medical conditions need to kind of get back out and about. How do we do this safely?
I think a key to getting out and staying safe is social distancing. I think that that's the most important thing that's out there. So you social distance, you wear masks, you wash your hands, you don't touch your face, and that's going to make you don't congregate in small places with large crowds without masks. So I think the idea that the world's going to go back to normal is ridiculous. It's not. I'm not going to a movie theater. I'm not going to a restaurant. I'm not going to the theater. And it'll be a long time before I do things like that. I think, in fact, it'll be a vaccine before I do things like that. And I think I'm the majority of people.
I'm right there with you. I'm not going out into any major functions. I'm staying away from people. I'm even being careful on what paths I hike on. If there's too many hikers, there's other paths we can go to. No need to go for big areas where people are congregating. It's very, very dangerous right now. So some of our patients with HCM, and I will say, I don't know what your experience has been, I'll ask in a second, but we do know of a handful of people with HCM who had COVID, definitely had COVID, and did well with it. Nobody that I'm aware of right now in the United States was hospitalized. I do know of some people in Italy that were. We don't, in the United States, I'm not aware of any HCM COVID-related deaths. What do you know?
I'm not aware of any HCM-related deaths to COVID also. Our patients are very, very concerned, of course. When you look at the underlying cardiovascular conditions that have been reported to increase the risk of COVID, it doesn't appear that HCM would be one of them. It's coronary disease, it's hypertension, it's diabetes. It's the sort of things you would expect to be associated with immunity. But I don't think there'd be any reason to think that HCM puts you at higher risk.
Yeah, I'm seeing that to play out, but I also think we have a more cautious population that knows that they have an underlying cardiac condition. And I think that level of caution has paid off well for many of them. The hand washing, the mask, the distancing, all of these things matter. But now we're going to go back out at least to work for most people and to school for some come fall. Are there any extra special tips that we should be taking, or is it just follow the guidelines?
I think, everyone should have their bottle of Purell. It should be on their desk. I think that especially inside buildings, masks should be worn when you're in any sort of public area. And if you so happen to be lucky enough to work in a private office, then I think a mask can come off in a private office. But I think any time that there are people interacting in a common space, masks should be worn. hands washed just dozens of times a day, or Perel used dozens of times a day, I think is also crucial. Another thing I think that the mask really help with is they keep you from touching your face. I mean, it's very hard to not touch your face. It's very difficult for me and for most people. But a mask helps because it just draws attention to something on your face.
I've been a mask wearer on planes for 3+ years now, and trains. And if I were in a supermarket during flu season, I would actually wear one. I used to be looked at as the germophobic lady down the street. Now y'all have mask envy because I have the pretty VOG masks. So I've actually reached out to VOG mask when they come back into production in the United States, that we, the HCMA, are probably going to buy a bulk amount so people can get these very nice quality VOG masks that I've been using since my transplant. I believe in it. So people were asking me where to get them. Reached out to the company and we might be able to provide them to you.
What are they?
They're called VOG masks, VOGMASK. It's a N95 quality reusable mask, good for up to, I think it's 6 months out of the package. So you can kind of wipe down the outside. It's a really nice quality mask. They're fit nice. They're soft. They don't scratch your face, and they have the moldable nose. So they have a really nice tight fit, and they're even almost comfortable in hot weather. Almost.
Well, yeah, I'd be interested.
Okay, I'll keep you posted.
Yeah, put me on the list.
I will put you on the list as soon as we hear back from them. So masks, hand washing, social distancing, this is the best thing that we can do. And if you do happen to feel a little bit under the weather, stay home.
Absolutely.
Yeah.
Absolutely. And then a lot of companies are going to employ screening. I mean, our hospital and our clinic employs screening that we have our temperature taken every time we come into the building, and we get handed a mask. I think that's going to be pretty common because there's so many asymptomatic carriers out there that probably have a fever, a low-grade fever.
That's going to be tricky to figure out. And I'm wondering if some of the people who've been a little bit upset about the quarantine and the shutdown are going to be compliant. I hope that they are, understanding that we're all in this together. No matter how much we want to think it's somebody else's problem, this is literally the world's problem right now.
Absolutely. Absolutely.
So now that we've kind of gone through all things COVID, right now, are you seeing any differences in people's attitudes about coming into the emergency room? Are they coming in more or less frequently for A-Fib and stroke and heart attack during COVID?
Yeah, that's been an amazing story across the country, that hospitalizations for strokes, MIs, A-Fib are down by 50%. And there's no reason to think that COVID is curing people of these diseases. I think the concern, and it's well-founded, is that people are afraid to go to the ED because of COVID. And therefore, they're sitting at home and having their MIs and having their strokes at home and never getting medical care. That's a big concern. Potentially more people could lose their lives from not getting medical care for these conditions than are going to lose their lives from COVID.
We are dealing with a tricky balance here, aren't we?
Yeah, it's difficult. I mean, I don't want to go to the ED. So I understand it. I do get that. But people are likely dying at home of MIs, because they're afraid to come to the emergency room.
I've seen it happen in my own community twice. Younger guys having heart attacks and not surviving them. So I don't know if they didn't go because they didn't want to go or they didn't know. But I think it's odd that two people quite close to myself and community and were lost to this under the age of 60.
Right.
It's kind of scary.
Yeah.
So we have a lot to learn still about what are we going to do come fall when flu comes back and maybe this is still here. How do we segregate our emergency rooms? Is that part of what we need to think about, is how we view triaging?
Oh, I think we're already definitely triaging here. And I think we're not the only ones, that we have a separate unit in the ED for COVID, concern of COVID. And there's separate units in the hospital, both intensive care units and the wards. So there's sequestration of individuals already. That will continue until COVID's done. I mean, that's going to be, until the vaccine comes out, there's going to be sequestration of people that have fever and viral illnesses.
And I hope we do come up with a vaccine somewhat soon. And let's hope that everybody understands that vaccines are our friends and
Yes.
they're there to control controllable illnesses. So let's hope things move in the right direction there.
I found it amazing. They did a survey in New York City during, 4 weeks ago during all this pandemic there. And they said, if a vaccine were available today, would you get it? And only 2/3 of people said they'd get it. I was floored by that.
There is a very strong anti-vax community in the region. So that's going to become an issue. And whether you're pro or anti vaccine or pro or anti-science, whatever you want to call it, you're going to have to make some really difficult decisions. And I hope that this group of people make their decision based upon fact and science.
I hope so too, because the only way we're going to get through this is herd immunity. And you need a high percentage of people to be vaccinated or to get the disease to get herd immunity.
And it's probably a lot more cost effective and life-saving effective to go with the vaccine over let's just toss the coin and see if you get really, really sick and die.
Right. Like Britain did when it started.
Yeah,
exactly. They learned their lesson. Yes.
That they did. So there's a lot going on, and I'm sure some of our comments have stricken controversy with certain individuals who are watching, and we're not trying to upset anybody. We're just trying to bring to reality the real situation that you're going to have to make soon. Do you take a vaccine, or do you risk getting sick and potentially having a life-threatening consequence? You get to choose. You're grown-ups, but the other grown-ups out here want to stay here too. So
I know what I would choose. I'll be the first one in line for a vaccine.
I'll be right behind you. I'll let you go first as a transplant patient, just in case. I'll let you try it out first. Okay, so now we're going to start reopening. Are you guys going to start implanting devices again soon in the non-urgent cases? What's happening that way?
Yeah, we actually already have. Again, we shut down our lab for elective cases for 8 weeks. But now we realize, with opening up of the society and with patients really needing care, we've opened up the lab. So now we're back to doing ablations. We're back to device replacements. We're even back to implanting ICDs for primary prevention. So we're not as busy by design. We are asked to only go to 70% of volume for the next month. And largely that's because of PPEs more than anything. The world is short on personal protective equipment. We're not short on defibrillators. We're not short on ablations. And, patients, it's an interesting mix. When I call patients to reschedule them, about 2/3 of them said, you know what, I can wait a little bit longer. But it's interesting, of those 2/3 that said they could wait a little longer, after a week, half of them called back and said, I've waited long enough. let me get on the schedule. And that's what we're finding. Probably about 2/3 of people still want their procedures done, and the other third are just afraid. And again, I'm not blaming anyone for being afraid. I'm afraid of getting COVID. I don't want COVID. So I get it. I get not wanting to come to the hospital. But I'm coming to my office and the hospital now nearly every day. I get my mask. I get my temperature taken. I wash my hands. I use Perel. Every time I see a Perel station or whatever, cleaners there, I use it. So I'm very, very careful, but still, I understand.
I think it's great that we're getting back to, I hate calling them elective procedures because I don't really think of a defibrillator as truly elective by nature. Right. And nor do I think of myectomy as elective. However, that is their classification. It's not immediately life-saving. That's true. So I'm glad that we're getting back to getting these devices in. I know a lot of people, even some members of my own family, their devices are to end of life, and it's time to consider when to go back in and put them in. And that's a balancing act. You wait till you're past your curve and everything seems safe, and then we'll go back in.
Yeah, and I actually think now is an ideal time because now the hospitalizations in Texas, at least, are the lowest they've been in 6 weeks. And I'm concerned it's going to get worse before it gets better.
Yeah.
With opening up. So I actually think we have a window now of a month or two. I think it's going to get worse again.
I hate to agree with you, but I'm going going to agree with you. I'm spending a lot of time in my yard. It looks fantastic finally for the first time in years because there's nothing else to do other than garden.
Right.
So you got to look at your advantages. So I want to pivot our talk away from COVID and the scary times that we're living in, and go to an equally scary time for those with hypertrophic cardiomyopathy. And that is for those with atrial fibrillation.
Right.
And I want to talk about a lot of things regarding A-Fib. But first, let's start with, what do we think the reason is that 25% of HCM patients develop atrial fibrillation?
Yeah, there are a number of reasons for that, and we don't know them all. But we know that some of the risk factors for AFib are atrial scarring, high left atrial pressures, atrial stretch, all of, in addition to male and heart disease and valve disease. But those are the features that in HCM are present. The genetic defect affects the atrial myocytes just like it affects the ventricular myocytes, so they're abnormal also. And then you have a stiff left ventricles that transmits pressure back to the left atrium, so that increases the left atrial pressure, and then that left atrial pressure increases the left atrial stretch. So it's it's not surprising at all that 25% of HCM get AFib.
So we have this problem where we have a non-compliant left atria, like we have a non-compliant ventricle, but for opposite reasons in a sense, and thereby the arrhythmias that can originate in the atria and make the heart quiver at the top as opposed to beat at the top are pretty common, right?
They're very common. Yeah, as you said, 25% of patients with HCM, and if you follow patients long enough, especially the ones that develop HCM, in their childhood or adolescence, it's much higher than 25%.
Absolutely. So once somebody starts going into atrial fibrillation, why don't you explain the difference between these once in a while occurrence paroxysmal AFib versus persistent AFib, and when is the sweet spot to maybe jump in with more aggressive therapies?
Yeah, so the typical progression of AFib is that you get a few minutes, goes away, and then 6 months later get a few more minutes, and over the course of several years you're getting longer episodes and more frequent episodes. So that's when it's called paroxysmal AFib. And again, the progression can be very quick in some people, that they can move from paroxysmal to permanent in a year. Other people, it's going to take a decade. But AFib almost always is a progressive disease. And, we know a lot about how to treat AFib. And the cornerstones of treatment are anticoagulation and going for a rhythm control strategy. And so these are important discussions to have with patients, important thoughts for patients to think about. How much AFib before I start to get blood thinners? I think that's one of the critical questions. We know that patients with HCM are at high risk of stroke when they have AFib. And so we don't look at what we call the CHADS-VAS scoring system for non-HCM patients. Right. It's a mistake to use that scoring system for HCM. If you have HCM and you have enough AFib, you should be on blood thinners. The question is, what's enough? We know based on other series and based on other conditions that 24 hours is clearly enough. What we don't know is, and we know that 6 minutes and less is probably not enough, but it's between 6 minutes and 24 hours where we don't know. Now, clearly, the closer you get to 24 hours, the more it just doesn't flip a switch at 24 hours. But so the longer episodes you have, the more episodes you have, the more you're at risk of stroke.
Now let's talk about that a bit. So today, ironically, not AFib related, is the 30th anniversary of the procedure that I had that caused me to have a stroke. So this is kind of my stroke awareness day. So I'm glad we're talking about this today. That was from endocarditis, completely different than atrial fibrillation. However, blood clots. I mean, what else can they do other than cause a stroke? Can they cause problems in other parts of the body?
Yeah, it depends where the blood clot goes. The blood clot can go north and go to your brain. That's by far the worst. But it can go to anywhere. It can go to your fingers. It can go to your toes. It can go to your kidneys. And and it can cause damage in any of those areas depending on the size. Now, unfortunately, it does not take a big thrombus to cause a relatively sizable stroke. A thrombus the size of a piece of rice would be a major stroke. And if that same piece of rice thrombus went to the kidney, you'd probably be fine. You'd probably be asymptomatic. So the rest of the body is a little bit more forgiving than the brain. The brain is not forgiving. Mm-hmm. There's no collateral blood supply. There's even a small clot that goes up there, there'll be a stroke.
And there are two schools right now in anticoagulation, really. First, let's talk about the one that people think is an anticoagulant, aspirin. What's the usefulness of aspirin in this case?
Zero. There have been many studies in the past on aspirin. All of them all but one showed that aspirin was not beneficial for A-Fib. The one study that showed it was beneficial has pretty much been debunked and thought not to be valid. And it's really, we've come to appreciate aspirin is, as we like to call them, Jolly Ranchers for A-Fib. They really don't prevent strokes. And to be honest, there's no reason to think they would, because it's an arterial thromboembolism that attaches to the wall of the left atrium. Aspirin is a platelet, and platelets aren't the problem. Aspirin is an antiplatelet, and platelets aren't the problem in stroke and in clots in the heart. So I don't use aspirin anymore. I think it's a false sense that you're really doing something, and you're not.
Thank you for that. I've tried to explain that to people before, so I think you gave a much better explanation than I do. I refer to it as going into a swimming pool and peeing. It doesn't do much. So yours is far more scientific. So now let's get into old school anti-thrombotics and warfarin. What does it require to be on warfarin today, and specifically in COVID times with INR testing?
Yeah, so warfarin is a really funny drug. I mean, people think that the newer anticoagulants are funny. They're not. Warfarin is almost unique of drugs that we use, in that the way warfarin works is by poisoning a protein synthesizer in the liver. So it stops that protein from being made. And you have to be very careful with the dose. You have to be just the right amount of poisoning of that protein. Too little poisoning, and you won't be effective. Too much, and you're at risk of bleeding. Now, if the INR is good, or if the levels are good, it's a very effective blood thinner. I don't have a problem with it as an effective blood thinner. I have a problem with it more as a practical matter. It's a difficult drug to be on because it requires watching your diet, not eating too much vitamin K food, or eating the same amount of vitamin K containing food every day, and that it requires blood draws to maintain your, the vitamin K protein in the correct level. But if people can do that, again, I want to emphasize, it's a very effective stroke preventer in A-Fib. Mm-hmm. So I don't want people to go away saying, oh, I should never be on warfarin, because that's not the case. If you can deal with it and your INR can be kept between 2 and 3, it works.
So that's the old school. And truth or not truth, warfarin came from rat poison.
Truth. It is, yeah. It's an interesting story. It was discovered in Wisconsin, and it's from a plant, foxglove, which actually a lot of us have in our gardens. And cows in this certain pasture were bleeding out. And so they asked the University of Wisconsin to come out and take a look. And what they discovered is, so they tested these cows. They were eating foxglove. It was poisoning their liver. They weren't producing this clotting protein, and that's how warfarin was born.
Okay, so not everybody's a real big fan of taking something that has such a history, and they find out that they need to go on an anticoagulant, and they start doing their research, and they see warfarin is related to rat poison, which you just explained. So they want to try something new. What are the new things, and what do they do positively and negatively?
Yeah, so these are the new agents, aren't so new anymore. The first one's been out, I think, over 10 years. So I like to call them direct-acting anticoagulants rather than novel anymore, because they're no longer novel. These are more traditional drugs. I mean, again, that's it. People think warfarin's the common drug. Warfarin's a weird drug. These are the drugs that when they're in your system, they prevent clotting, and when they're not in their system, they don't. So these are like blood pressure pills and, antihypertensives. These are the normal drugs. So these, what we call direct acting anticoagulants, are effective as soon as they get in your bloodstream. And they, wash out of your system after 3 or 4 doses. Most of them, they're either once a day or twice a day. They've all been assessed in very, very large clinical trials against warfarin. And in these trials, there's 15 to 20,000 patients each. There's 4 of them, all have been tested in trials against warfarin. And all the trials have been pretty consistent in that people on these drugs have generally fewer strokes and generally fewer bleeds. And it's close, but generally they're a little bit better than warfarin in preventing strokes and in preventing bleeds. Pradaxa, the first one out there, had an increased incidence of GI bleeding, gastrointestinal bleeding, and that's why you'll see it advertised as a class action lawsuit, because it increased the risk of GI bleeding compared to warfarin. It did. I'm not denying that, but it decreased the risk of strokes and it decreased the risk of brain bleeding. So I'll take a GI bleed any day over a brain bleed or a stroke. And that's what's unfortunate about these class action lawsuits, is they're scaring people away from taking these drugs. And there's class action lawsuits with all these drugs because of bleeding. That's what they do. They are anticoagulants.
So when people start seeing, these commercials and wonder whether they should go old school and stay on warfarin or new school and deal with the possible complication of a GI bleed, this is a perfect opportunity to have a really one-on-one discussion with their EP team, hopefully in our community, an HCM Center of Excellence
Right.
EP, to really wage the pros and cons of each for that person. Would that be an appropriate statement?
Absolutely. And again, warfarin works. So I'm not an anti-warfarin person, but I just, from a practical matter, it's hard. It's hard to get the right dose. And so I write very few warfarin prescriptions anymore. Almost all, my prescriptions are for NOACs or DOACs.
And what does that stand for?
Direct acting anticoagulant.
Okay. We don't like to use jargon without telling everybody what jargon means. Okay, so I'm going to do a hybrid question here. A-Fib, warfarin, times of COVID. Can people get their INRs checked? Can they go to their Coumadin clinics?
Yeah, that can be an issue for sure. In fact, your Coumadin clinics have to stay open. So our Coumadin clinic has stayed open throughout all of this. And in fact, the one COVID positive exposure we had was a patient coming to the warfarin clinic.
Oh.
COVID positive and exposed to the clinic. Now, there weren't many people in the clinic. Luckily, no one got it. But that was our COVID exposure. They do make INR units to be used at home. And many people have those units at home. So if you have a INR unit at home to check your Coumadin level, then you're good. You don't have to leave the house.
So are insurance companies paying for these a little bit more easily today than they had in the past?
By and large, they are. I mean, because they're realizing it's actually cheaper to do it at home. Mm-hmm. And they're realizing it's cheaper than putting someone on a newer anticoagulant.
Absolutely. So we have a question here. If somebody said, what if, let me bring Diane's question up, show it on the screen. What can you take if you can't take NSAIDs due to bariatric surgery? Are you talking about anticoagulation there, Diane? Or are you just talking a general NSAID question? We'll wait for clarification on that one. It didn't make much sense.
For clarification, even without clarification, I think there's an important question there.
Okay.
People on anticoagulants are told not to take NSAIDs. And that's because NSAIDs are antiplatelets. So you're knocking out the antithrombotics and the antiplatelets. So you're making your blood even more thin. But also you're increasing your risk of ulcers, which nonsteroidals do. So there is a real concern about taking nonsteroidals and an anticoagulant. And the same thing goes for aspirin. Many people have been started on aspirin 15, 20 years ago just because it did decrease the risk of MIs in several studies. But it actually, aspirin's sort of fallen out of favor for the primary prevention of MIs. And the only people that should be taking aspirin are those people that have documented coronary disease. So if you have A-Fib and you don't have coronary disease, you shouldn't be on aspirin. And I think we see this way too often, is that people are on an anticoagulant and on aspirin despite having no real indication for aspirin.
Okay. We have a question about mechanical valves. Having a mechanical valve, Coumadin is the only blood thinner you can take, correct?
That is correct. And what's happened with this is that Praxa, the first anticoagulant out, actually started a clinical trial randomizing people to Coumadin versus Praxa with mechanical valves. And it didn't work. So if you have mechanical valve, Coumadin is the only blood thinner you can take. Now, that's not true of porcine valves or pig valves. If you have a pig valve or a cow valve, you can take these newer agents.
So it's just strictly the mechanicals you can't.
Strictly the mechanical.
Okay. Let's pivot away from anticoagulation for a moment and talk about when to ablate. How much A-Fib should somebody endure before they contemplate doing an A-Fib ablation or radiofrequency ablation?
Yeah, this is a big question, and certainly a shared decision-making question, because this is something that the patient has to want also. You know, as I discuss with my patients an ablation and when is the correct time, there are a number of factors that go into that. One is, and certainly the most important question, is how much is it affecting the quality of life? If it's a dramatic effect on your quality of life, not only when you have A-Fib, but because you're concerned you're going to have A-Fib, then that's the time to get an ablation or contemplate going on drugs. And we can talk about drugs versus ablation. If it's not affecting your quality of life and you're perfectly fine having episodes of A-Fib and you're on blood thinners, then fine. There is, though, another concern. If you wait too long and let the left atrium dilate, scar, there will be a point of no return for the efficacy of not only ablation, but drugs also. The biggest factor, the two biggest factors that make a difference in the efficacy of ablation are the size of the left atrium and the length of time you've been in A-Fib.
Okay, I'm going to dial back because I jumped ahead and that was my fault, not yours. So you're in A-Fib. You're already on a beta blocker or calcium channel blocker for your underlying HCM. You go into A-Fib. What drugs would you consider adding on as a first line of defense against atrial fibrillation specifically?
Yeah, so the beta blockers and the calcium channel blockers, which we use frequently for both A-Fib and HCM, it's important to realize they're not going to prevent A-Fib. That's not how they work. How they work is when you have an episode of A-Fib, they'll slow down your heart rate. So they're good drugs for that, but they're not preventing A-Fib. So the drugs that prevent A-Fib are called antiarrhythmic drugs. So we abbreviate them AAD, but they're antiarrhythmic. These work on ion channels in the heart, so they're very potent. And that's important to realize. They're much more potent and problematic than beta blockers because of affecting the ion channels. We don't use a whole class of agents in people that have heart disease. So, and we do not like using, class 1 agents in patients with HCM. So we're really limited to 3 or 4 drugs, and that's Ticacin, Sotalol, Amiodarone, and possibly Maltac. But those are your really choices for antiarrhythmic drugs. And
what about disopyramide?
Well, disopyramide is used primarily for outflow tract obstruction and heart failure symptoms. And it's safe, but it just doesn't do much for A-Fib. If a person with HCM has A-Fib and outflow tract obstruction, yeah, disopyramide is a perfect drug for them, because actually reducing the outflow tract obstruction may be all you need to reduce A-Fib. So I do like disopyramide for that, but it's not that most people don't get a lot of A-Fib relief from disopyramide.
What's the first go-to? What's the order that you would use these drugs?
Perhaps, I agree with disopyramide first. So that would be my first one. My next one would probably be Thickening. Again, it depends on the QT lengthening. It depends on how old they are. It depends on how many years you see them using drugs for A-Fib. I will say, in terms of efficacy, they're all roughly similar. And we published a paper that, most people will stay on an antiarrhythmic drug for 6 to 12 months. So that's not very efficacious if that's all the time you're staying on a drug. So what we're seeing with antiarrhythmic drugs is none of them tend to work that well. Amiodarone works the best in both patients with HCM and patients without HCM, but amiodarone has real problems with toxicities. And can affect the liver, the lung, the thyroid, the skin, the eyes, almost every organ system. In fact, every organ system but the kidneys. So amiodarone is not an attractive choice for a young person with AFib.
So we maybe go to Thickening. Amnio is kind of last resort, and then you've got what, Septal and
Multec. Yeah, Multec I don't think is very effective either.
I was all excited for Multec when it hit the market, and then I was disappointed. It didn't seem to work very well.
You're with all of us. We were very excited when it hit the market. And I think there's something here. There's another story here. There are no antiarrhythmic drugs under development that I'm aware of. And that tells you what the pharmaceutical world, because the pharmaceutical world thinks of these drugs. This is not doctors saying don't develop these drugs. This is the pharmaceutical world saying that if we develop a drug, it won't be used.
So you gave me a perfect segue to explain something here. On June 26th, the HCMA will be holding a patient-focused drug development meeting. And the purpose of this meeting is to speak directly to the FDA about what the needs of our community are. We need all patients to come and join us online on June 26th and tell the FDA what drugs you need developed. We need better antiarrhythmics, but they're too afraid to make them because the downhill consequence is that they might cause an arrhythmia. Well, we already know the risk. We already are having the arrhythmias. Help us try to stop it. We need to explain to the FDA that we're willing to take some level of risk as the patient population for some degree of reward. And the only way they're going to have the courage, the drug makers and the FDA, to go forward with these types of studies is to hear directly from the patients who are affected.
Right.
We need to all come to the table and say, we understand we're going to put ourselves at a little bit of risk, but hopefully we're going to get rid of a lot more risk. So come to the table on June 26th and speak your mind. It's really important.
Right. And there's a whole series of drugs, classes of drugs that could be beneficial for HCM. There's the antiarrhythmics, there's the ones that increase relaxation, there's the ones that increase or decrease progression. I mean, there's so much hope that better drugs could be found.
They're out there. We just have to have the courage to go find them, and the courage to be the trial participants, the courage to be in industry and put their money here. They have a choice of where they're going to put their money. We hope that they consider us and look at this disease state as something that is manageable with their help. So we go through the drug phase, then we get to the ablation phase. Why don't you explain what an ablation is?
Sure. So an ablation is a procedure where we cauterize the area around the pulmonary veins. So what we've learned over the last 20 years is the pulmonary veins are the important triggers for AFib in all patients. We used to think it was just the idiopathic AFibs or the people alone AFibs, didn't have any heart disease, that those were the people that had these pulmonary vein triggers. But what we've seen is that even heart failure, even HCM, it's still these pulmonary veins that are the problem. And what the issue is you have the left atrial tissue, that's muscle tissue, and that grows into the vein, which is non-muscle tissue. And for some reason, when that happens, these cells get very irritated and they will take off and beat. And when they take off and beat, they can cause AFib. And so what we do is we need to isolate or actually kill those cells that go into the vein. And so the first ways we did it were radiofrequency, where we would take heat, cautery, in a point-by-point system and just go around the veins. And we have a beautiful 3D mapping systems that can be very, very accurate in terms of showing us where we've been, where we've ablated, and where we have to go. So we can actually be very accurate with this point-by-point system. Another system that's used is cryoablation, where you take a balloon, blow up the balloon in the left atrium, put it in the vein, and then freeze. And that creates a circumferential lesion 360 degrees. Some physicians prefer one over the other. I'm a cryo fan, but other physicians are radiofrequency fans. And whatever, I would say whatever the physician is best at or feels more comfortable with is the way you should go. For both of these procedures, in terms of a patient perspective, they're very similar. You go into the hospital. In general, it's done under general anesthesia. Then you get access through the femoral veins in both sides, go up into the heart with these catheters, and then cross from the right atrium to the left atrium. And it sounds gruesome, but actually we're looking at it with a miniature camera that we actually, we used to do this with fluoroscopy. Now we're actually watching with a miniature camera. So it's become much, much safer. We get to the left side, and then we anticoagulate, and then you do either cryoablation or radiofrequency. Typically, we're on the left side for 40 minutes, and then we're out in the whole procedure. What used to take 10 years ago, 10 to 12 hours, now we're done in 2 hours.
Wow.
So it's become a dramatically different procedure than it was 10 years ago. It's become both safer and more efficacious. And that's why we're actually moving to ablation sooner than we did in the past.
So we know HCM AFib versus non-HCM AFib does act a little bit differently. That we tend to recur our AFib more often than the non-HCM population. I just say it's because we're so much smarter, we're able to create new pathways all on our own, which is not necessarily a good thing here. But why do you think we actually do this?
It's the same reason there's a higher incidence of AFib in HCM. It's the left atrial stretch, it's the size of the left atrium and the pressure of the left atrium, and the fibrosis of the left atrium. So all those same features that cause the increased risk of getting it create the increased chance to get it again after ablation or drugs.
So we're quoting generally about a 40% success rate on a first time. Is that still accurate in your opinion?
It depends. If you take someone that's paroxysmal and it has paroxysmal AFib for only a few years, the success rates would probably be 80%.
Be higher.
You take someone that's been in AFib for a year or two and their left atrium's 4.5 centimeters, it's probably 40 to 50%. You take someone with HCM that's been in AFib for 5 to 10 years, their left atrium 6, it's probably not worth doing.
So you bring to point that it's really important for people to understand HCM, not just AFib, before they go ahead and do one of these procedures, right? As a physician.
Right.
So patients are well advised to use the Center of Excellence system that we've created at the HCMA and around the country so that they can get to the highest volume care possible to make that best choice rather than having an unnecessary cardiac catheterization, which I assure you is not fun.
Right. Yeah, it's the volume is important. The more you do of a procedure, the better you become. And that's true not only of the individual person, but it's true of the hospital system also. So I would encourage patients to ask, how many procedures does your doctor do a year? And how many procedures does the hospital do a year? Because that's a very important metric. One study showed that, 60% of the AFib ablations in the country were being done by physicians that did less than one a month. And that's a surprise to me. I mean, I wouldn't want my AFib ablation done by someone who hadn't done one in a month and a half.
No, for those of you who aren't sure how things like this are managed and how to look at typical numbers, in an HCMA recognized Center of Excellence, for example, you'll see 40 plus myectomies done per year on average. And if you go out to somebody else and they do one per year, their outcomes really aren't so good. Right. So the same concept stands with ablation, radiofrequency or cryoablation for AFib, you want them to know what they're looking at and be very familiar with our unique anatomy before they go ablating part of your, heart away. Somebody asked a question earlier about using ablation for hypertrophic obstructive cardiomyopathy. To that, I believe you're referring to an alcohol septal ablation, which is not done by an electrophysiologist like Dr. Ling, but done by an interventional cardiologist to attack an incredibly different problem called obstruction, which is topics for other and previous conversations. Today, we're talking about ablations for arrhythmias. And I'm going to pivot that for just 1 second to say you can also do ablations for ventricular arrhythmias as well, although not so common in HCM, correct?
That is correct. Ventricular arrhythmias in HCM can be polymorphic or ventricular fibrillation or monomorphic. And the monomorphic ones are the ones that can be ablated. Typically, the kind of patient with hypertrophic cardiomyopathy that gets those are the people with apical aneurysms. Those are the population of HCM patients that get monomorphic ventricular tachycardia, and that's the rhythm that is ablatable. VF is not really ablatable, but VT, monomorphic ventricular tachycardia, is.
Okay. I was just waiting for the other question because you use a generalized term like ablation. It can be used in any part of the body in a number of different ways. So I just want to make sure they're understanding. Jen wanted to share with us that I'm not sure if that's a guy Gen or girl Jen.
General.
Yeah, I'm not sure. So Jen is Jen. Jen was afraid to have an ablation. She waited a long time, wanted to get her heart back in rhythm, really helped speaking with 2 different patients who had ablations, and she reports that she can now walk 6 miles a day. So the ablation worked, and it's a good concept for some people.
Yeah,
ablation took 6 hours.
Yeah, I mean, it's not like it's an emergency and has to be done within the first few weeks of getting diagnosed. But what you don't want is you don't want to get to that state where you're a persistent AFib. And a persistent AFib is someone that's needing cardioversion after cardioversion, because that, in those patients, the success rates are going to be lower. Paroxysmal AFib, especially if you're having one episode every 4 weeks, there's no terrible rush there.
Jen is Geneva, so now we know.
Okay.
Okay. I'm going to jump to a couple of quick questions here. And so some of them will be, it's rapid fire session here, and we're going to let you get off to your procedure soon. Can RF ablation be used to reduce septal thickening?
Yeah, this is the, so yes, but there was one study from one center that they used RF ablation. But if you look at the results, the number of people dying, the number of complications was tremendous, just tremendous. And in a center that was doing a lot of them. So I think, although you can do it, I would never let someone do that to me based on that one retrospective series. So no, I don't think you'll see that in the States. You shouldn't see that in the States.
And I am with him on that one. Somebody wants to know, you are or were their doctor. What does A-Fib feel like compared to PACs or PVCs? And as a follow-up question to that by our next questioner, can you ablate PVC?
Yeah, so APCs and PVCs can cause palpitations, or the feeling of an irregular heartbeat or extra beats, things like that. So that symptom can be identical. What other symptoms people get with AFib are fatigue, trouble breathing, exercise intolerance. Those symptoms aren't generally seen with APCs or PVCs, but the palpitations, the feeling of an irregular heartbeat, can be identical. And then the only way to know would be to get a monitor. Yes, AFib can be picked up by ICDs, both by the transvenous ICDs and by even the subcutaneous ICDs that have an algorithm in that looks at, for AFib. So yes, they can be picked up. Typically, AFib is not asymptomatic in our patients with HCM, where in other people it can be asymptomatic and just picked up on their EKG or on their device. That's unusual for AFib to be asymptomatic in an HCM patient. And that's a problem too, because it means that, HCM patients do not like a rate control strategy. That is staying in AFib and just controlling the heart rate. Most patients do not like that. They're too symptomatic. Related to PVC ablation is similar to VT ablation. Yes, you can do PVC ablation in patients with HCM, and patients with HCM can have, PVCs that are coming from the outflow tracts. They can have it coming from anywhere, but yes, they can be ablated.
It's not commonly done though, is it?
No, it's not commonly done, because it's probably not related to HCM. So it's not that people with HCM have more PVCs. So they may be completely unrelated. And so that's why I think it's not commonly done. It's not generally a big problem in patients with HCM.
Yeah, I think at the end of my old heart, I think I was having somewhere in the neighborhood of 10,000 PVCs a day. I didn't know what a normal heartbeat felt like at the end. And at that point, it was just too far gone.
Right.
Is AFib common after myectomy?
Yeah, AFib is common after any cardiac surgery. And the reason is because there's inflammation around the heart that occurs for the first few weeks up to months. And it's that inflammation around the heart that causes the AFib. Typically, once the inflammation dies down, the AFib is gone. So it's not going to cause permanent AFib or long-standing AFib. It's really just for the peri-op period when there's inflammation.
There's a question here. I want to just take a look at it a little more closely and see what it's. Electrophysiology does 1 VT 9-second non-sustained and 48-hour Holter. Don, is it relevant? So if you have an event of a 9-second NSVT, what does that mean in HCM?
Yeah, non-sustained VT is one of the risk factors for sudden death. And it depends on how long it is and how fast it is and the age of the patient. We get more concerned about non-sustained VT the younger the individual is, the faster it is, and the longer it is. So it doesn't mean you automatically jump to an ICD for everyone with non-sustained VT, but it is one of the risk factors. And one episode in 48 hours is enough to be a risk factor.
One is done because if you caught one in 48 hours, you got a lot more hours in your year. How many more times are you going to have this? And a lot of times you find that when you do wear an event monitor, it's picking things up in your sleep that you would never report. So there's really an importance to event monitoring from the EP point of view. I know some of you think you're using event monitors for obstruction related issues, but it's really for this guy over here and his colleagues, it's for EP. What is your heart beating like? What are the rhythms? So
yeah, it's important to recognize non-sustained VT in someone over age 60 probably means nothing for HCM in terms of a risk factor. So all non-sustained VT is not the same in hypertrophic cardiomyopathy.
And I think we're going to learn more about that in the upcoming guidelines this fall. We hope they'll be a little bit more specific there on risk factors. We hope. Nobody can talk about it right now. They'll get heart handcuffs put on them and be taken to heart jail, which is okay. We get that. So I'm going to wrap up here. We've been kind of trickling through with the questions. One follow-up to that is there any, how long should you follow up? If you are over 60 and you had one event of NSVT, should you do a 30-day monitor and see what it shows?
No, I don't think that's necessary if you're over 60. You already know you had an episode. I think, you don't need to know if you're having more to be from a risk stratification. Now, if you're doing it for symptoms, it's very different.
Right. So Don, I'm corrected. I thought Don was 63 in my brain, but he's 53. Does that matter? Yeah,
again, we worry a little bit more on people 53 than 63. Again, it's not like, again, at 60, the switch gets turned off or on. We'd worry a lot more about it in a 18-year-old than we would in a 15-year-old or a 53-year-old.
Got it. Okay. Well, I think we've answered a lot of questions today. Probably got some people curious about their anticoagulation therapy. I'm going to wrap with one last thing. How many episodes, actually 2, how many episodes of A-Fib is your level of when it's time to put somebody in an anticoagulant?
It's a very difficult question for short episodes. I think what I would say that makes it easy, if it's greater than 24 hours of AFib, that's easy. That should be anticoagulated.
Okay.
It's a little bit easy if it's less than 5 minutes. Probably not. It's gray between 5 and 24. And where I would make some distinction, that's where you have a shared decision. You say there's probably increased risk of bleeding with, well, not probably, there is increased risk of bleeding with these agents, but it is going to lower your risk of stroke too. It's that risk benefit that people care about. Someone that, does downhill biking and, crazy skiing, they may say, I really don't want that risk of bleeding because it's much higher in me. But again, it's that 6 minutes to 24 hours that is vexing. It also makes a difference how often. If you're having, 20 hours of AFib every week, yeah, that's pretty high. If it's, 7 minutes a year, that's probably pretty low.
So my second question, and thank you for that answer, is there are now home monitors. There are Apple Watches. There are what used to be called the Live Core, which is now the Cardio Monitor.
Right.
What do you think about these home surveillance opportunities for AFib?
I think they're great. I think they're very, very good. They're quite accurate in getting a good EKG, unless the person is quivering, but they can give a very high fidelity trace. And their algorithms for detecting AFib are modest, to be perfectly honest. They're not great. Their sensitivity and specificity is pretty poor. But they do offer you the opportunity to print out the EKG and bring it with you to your doctor's office. And they can look at them and say, is this AFib or not? So yeah, I'm a big fan.
I've liked them as well. They give a lot of reassurance. If you're not sure, to find out that thing that you felt wasn't dangerous, it gives you some understanding of what your normal is versus what abnormal is.
Right.
And let your doctor know what your abnormal is and what you're feeling. So I think it's a great communication tool. I think it's great help towards diagnostics, not necessarily diagnostics. So I think that's great.
And party tricks to see who has the slowest heart rate or the fastest heart rate.
Oh, I used to just freak people out with mine because I'd have all these pauses.
Mm-hmm.
You have to have some fun with it. Lauren has a question. Lauren, you're welcome to email me the question. I can forward it to Dr. Link for you. If it's a private question, happy to do so. We really want to let Dr. Link go now because he has to go off to do something else right now and, be a doctor and do procedures and the things that they do all day. I want to thank you very much for spending this hour with us. It went by really fast, but we got a lot of good information, and I think a lot of people are finding it very, very helpful. So thank you, and hopefully you can join us again when COVID is over and we can get into some really interesting research that I know you and I are going to be working on soon.
Well, thank you very much, Lisa. Thank you for having me, and thank you for doing all the work you do for the HCMA. It's a wonderful organization.
Thank you so much. All right, guys, we'll talk to you soon. Bye-bye.
Bye.